Assalamu alaikum, welcome back to our channel, The Vet Couple Talks. Today's video will see end-to-end anastomosis surgery. The animal has been properly restrained and positioned. Pre-operative fasting has performed to reduce rumen fill and intestinal contents. Broad-spectrum antibiotics, anti-inflammatory drugs, and fluid therapy are administered prior to surgery. The surgical site is clipped, shaved, and aseptically prepared using standard surgical scrubbing techniques as per field conditions. So basically, the procedure is performed when a diseased or non-viable segment of intestine must be resected and continuity of gastrointestinal tract is restored. In adult cattle, intestinal surgery is commonly performed under regional anesthesia combined with sedation. Local infiltration or paravertebral plug is administration to desensitize the flank region. Adequate analgesia is confirmed before incision. Common indications include intestinal obstruction, volvulus, intussusception, strangulation, necrosis, perforation, or severe trauma. The goal of the surgery is to remove the affected segment while preserving adequate blood supply and restoring normal intestinal function. A skin incision is made in the flank region over the selected surgical site. The incision is extended carefully through the subcutaneous tissue. Hemostasis is maintained throughout the procedures using ligation or cautery as required. Proceeding towards muscle dissection, the abdominal muscles are separated layer by layer following the direction of their fiber to minimize tissue damage. Care is taken to avoid excessive bleeding and trauma. Once the peritoneum is reached, it is carefully lifted and incised to enter the abdominal cavity. Now moving towards exploration, the abdominal cavity is explored to locate the affected intestinal segment. Gentle manipulation is essential to provide additional trauma. The disease proportion would be identified through discoloration, thickening, distension, absence of peristalsis, or compromised blood supply. Throughout the surgery, will take care of hemostasis and cauterization and ligation to minimize blood loss, as it would be very dangerous if excessive blood loss would happen in large surgeries or time taking surgeries. Now, after exteriorization, the affected intestinal lobe is carefully exteriorized from the abdomen. Moist sterile gauze or laparotomy smudges are placed around the site to prevent contamination of the abdominal cavity. Warm saline would be used to keep the tissues moist. As you all know, this is very important. When you exteriorize a tissue from the body, you need to keep that tissue moist. So you use warm saline to wash it up and keep it moist. After the isolation of the segment, the intestine is isolated using a traumatic clamps or digital occlusion to prevent leakage of intestinal content. Mesenteric vessels supplying the affected segments are identified and then they would be ligated. Firstly, here we are going toward the ligation of atraumatic clamps and ligation of that segment, and then after ligating it, we would proceed toward mesenteric ligation, which is very important as well. You need to be very careful over here in terms of choice of your clamps and putting the clamps over the intestine, as intestinal damage would be a disaster. So take all the time in the world and position your clamps accurately, atraumatically, so minimum damage to the intestine or tissues is done. And desensitization is also very important, as we want the animal to feel very less uncomfortable and be in a good state and in proper analgesia. This is what we really demand. After that, we'll go towards the ligation, which is again very important. Proper ligation is essential to prevent hemorrhage. Now, as I told you earlier, the proper ligation is the main step, and hemorrhage control is also very important, as end-to-end intestinal anastomosis is a life-saving procedure in fine practice. The success depends upon gentle tissue handling, proper surgical technique, maintenance of blood supply. So, if you are not going to maintain your blood supply, the tissue is going to be dead in a few days. So, maintenance of that blood supply is very important. It's kind of word of arc that you are going to re-establish the blood supply to that region, and through proper post-operative care, then the prognosis is going to be well defined. Now moving towards resection, the non-viable segment of intestine is resected using surgical scissors or a scalpel as per surgeon's own choice. It is very important that you stay comfortable in surgery. Whatever equipment you prefer as a surgeon is going to be important, and your comfortability is important as well. The cut edges should appear healthy, white, with good blood supply and normal tissue thickness. Now we'll prepare for an anastomosis. You know what is an anastomosis? It is end-to-end the connection of the intestine. The two healthy intestinal ends are aligned carefully to ensure proper orientation and lumen continuity. Here comes a very important point, lumen continuity. Now you are not going to resect so much part that the lumen is discontinued. Its thickness is not as flowing as it was earlier. So after proper resection of the non-viable segment using whatever you like, the cut edges should appear: one, healthy; second, good blood supply; and third, normal issue thickness with lumen continuity. Here we are washing with normal saline, as I told you earlier, that keeping the whole tissue moist is very important so that it doesn't dry out. There would be a minimum tissue damage, and for sure for aseptic procedures as well. Now this is a complete surgical video of end-to-end anastomosis. We didn't even cut a single part so that all of you can understand and can see what a surgery really looks like in field conditions. So in field condition, the asepsis is totally not achievable, but as per surgeon choice, and the surgeon would really try its best to do that using whatever possible to be in asepsis. The anastomosis is done in 3 layers. The first layer, an end-to-end anastomosis, is performed using absorbable suture material. Typically, a simple interrupted or continuous pattern is used as per surgeon's own choice and its own comfort, incorporating the full thickness of intestinal wall while avoiding excess tension. Again, asepsis is very important. Cleaning of the organs is important. Since you are working in a field condition, you need to do it like 20 or 30 times even during each step, because asepsis is very important. Care is taken to oppose mucosal surfaces without narrowing the lumen. Then we'll go towards anastomosis. Second layer, a second inverting layer may be placed to reinforce the anastomosis and reduce the risk of leakage. Now, in intestinal surgeries, why are intestinal surgeries so complicated? What is the major drawback, or what is the major post-operative complication that we will find in an intestinal surgery? That is peritonitis. Peritonitis is the silent killer. Peritonitis is what makes the prognosis good or bad most of the times. So there are normally three kinds of peritonitis. One is subacute, then acute, then chronic. The chronic would stay longer for months to years, and the animal would be a low producer and would gradually decline in its production, in its health, and everything like that. The acute, it would take about 3 days, like 72 hours, and would lead towards the death of the animal. And subacute, you are just, the animal is going to die anyways, and that surgery, when you are doing that, that the intestine is now out of your hand in terms of cleaning, or you have a major leakage that has happened inside the peritoneal space. So it is very important that you, before you start the surgery, this surgery or any surgery, you take your honor in complete confidence, because death or life is in complete hands of Allah subhanahu wa ta'ala, and a person, a surgeon or a doctor can do nothing if Allah is going to end the life. So we need to take him or her in complete confidence, tell her whatever complications can happen during the surgery or whatever complications are possible if post-operative care is not given appropriately. Even if you have a major leakage, or if you think that peritonitis is going to be 100% inevitable, then you have to tell the owner. You take her or him into confidence and tell her what can be done now to save the life of the animal. And if you think which is complete in your own observation, if it isn't possible, you can really ask at that time to slaughter the animal, to keep him from undue suffering. Well, that's all in my opinion. Your opinion can be different as well. So coming back towards the surgery, we are performing our layering of the anastomosis. We have done, as I've told you, it normally takes about two layers, so that the chance of leakage is minimized, which would ultimately turn lower chances of peritonitis. The common patterns include Lambert or pushing sutures, whatever your likeliness or whatever you think you have a grip on. Again, the choice of suture and the bites are very important. You know how to grip the scalpel, you know how to grip your needle holder in such a way. I mean, when I'm going to take a bite that is going to be a very forceful bite, so I would really grip my needle from towards the biting part, and when less force is needed, then I would grip it from the ending part. So it's completely upon your own choice. While doing this surgery at the in between the anastomosis layer, it is very important to reassess the alignment of intestinal ends before proceeding with the reinforcing layer, because the alignment of intestinal end is extremely important. Proper apposition of the mucosal surfaces would really ensure optimal healing and minimize the risk of leakage or stricture formation, which is very important. We didn't talk about the stricture formation. It is also a kind of blunder would happen if the proper apposition is not ensured. The surgeon must confirm that there is no twisting of mesentery and that the lumen remain patient throughout the circumference of the anastomosis. So there is no twisting of the mesentery and that the lumen remain patent throughout the circumference of anastomosis. Gentle handling of the tissue is essential, keeping it moist is essential, cleaning it is essential, as excessive manipulation can compromise blood supply and delay healing. Any bleeding point should be controlled and the suture line appear uniform without gaps as you are seeing or undue torsion. There should be no undue tension. Maintaining adequate moisture of the exposed intestine with warm sterile saline also help preserve tissue viability, which is very important. Your tissue must be viable during this phase. Ensuring correct orientation at this stage significantly reduced post-operative complications such as obstruction, dehiscence, or peritonitis. A well-performed primary layer forms the foundation for a secure and functional anastomosis. Attention to detail during this step often determines the overall success of the surgery. Mesenteric defect lower is very important as well. The mesenteric defect that is created during resection is closed to prevent internal herniation. Now, after the mesenteric defect closure and reinsuring if that's done appropriately, will move toward replacement of the organs into the abdomen. The repaired intestinal loop is gently returned to the abdominal cavity. The area is then rechecked for contamination, bleeding, and abnormalities. In terms of that, the organs are washed with warm saline, checking for contamination. Then we'll take the gauze and clean that all up, and then we'll push it back very gently into the abdomen. Here you are seeing that we are ensuring there no contamination maximum as per our own duty. We are ensuring no contamination gets inside the abdomen. Now that we have ensured that, now we are going to put these organs back inside the abdomen. The last step is abdominal closure for sure, and it includes the closure of peritoneum, muscle, and skin. The abdominal wall is closed in layers using appropriate suture patterns that gonna hold everything inside. So it must be done very carefully. Proper alignment of muscle layer is essential for strength healing and to prevent any further complications like breakage of the suture, rehystance. After doing so, we'll proceed towards the skin closure. The skin would be closed using interrupted or continuous suture. The surgical site would be cleaned and dressed. You would wash it all up. Now the skin would be closed using interrupted or continuous suture. Here Dr. Abdul Manan always prefer using forward interlock pattern on the skin, which you are would be seeing after this layer. The post-operative care is very important. If the surgery stands for 70%, then the post-operative care really stands for 30 to 40%. So it is very important. Important is the right antibiotic, the right anti-inflammatory medication. Fluid therapy is very important since the animal has gone through a stress, a major surgery. You must provide it with completely good fluid therapy that is needed, and you cannot miss that at any cost. After that, you will gradually reintroduce the feed, and after this surgery, you would also have to monitor for sign of ileus, paralytic ileus, or any infection or leakage. Early detection of complication is critical for survival, because as early as you detect any complication, we can target and for sure we can work on it. Now after this video, you'll also see the recovery video of this animal, and how everything is going all fine. So this is all for today. I hope so we were able to let you observe and watch every step of the video in detail. And if you have any further queries, again you can comment or you can contact us. We'll mention the number of Dr. Abdul Manan here. Thank you so much. Jazakallah. The suturing is complete over here, and surgery has been ended. Now you can also watch the contents of that resected part in the upcoming video, and you can see what was inside that resected loop. After this video, I'm going to show you the recovery video of the animal as well, so you can see the proper post-operative care would really lead you towards a healthy animal and a good prognosis of the surgery.